Because that's the only thing we could do.
We should take greater ownership of these patients.
Welcome to the next episode of Endoscopy Essentials, and a very warm welcome to Vikesh Singh from Baltimore, Director of Endoscopy, with a specific interest in pancreatology, correct?
That is correct.
So, welcome.
Thank you for having me.
Our topic is chronic pancreatitis, and in one of the previous episodes, we had Jacques Deviere with his lifelong experience in endoscopic therapy. Already in the discussion, narrowing the indications a little bit to, massive obstruction close to the papilla, etc., etc. But what I would be especially interested today is the how is the pain in chronic pancreatitis come about? And you have done a lot of research. So enlighten us. There are a lot of aspects beyond endotherapy, because there are only, I think, specific patients who might benefit. And please.
Yeah. First of all, thanks so much for having me, Thomas. It's really wonderful to spend some time with you here in San Diego, especially since we had an opportunity to spend some time together in China not too long ago. Yeah. Chronic pancreatitis pain is complicated, so I think that's probably a good place to start. I think we have put too much emphasis on ductal obstruction as being the primary source of pain.
On the mechanics.
On the plumbing problem, as I think it's a simple way to put it. Ductal obstruction leading to intraductal hypertension, I think, has been really the mainstay of managing these patients' pain really since the early 1970s, both from a surgical and endoscopic perspective.
Because that's the only thing we could do.
That is correct. Yeah. That's absolutely correct. And what's really interesting is that a lot of that was primarily supported by an N of 1 study that was conducted by a surgeon in 1970 who was based in Seattle, Washington. But he had shown in a patient with a pseudocyst that you could put a pressure catheter in. And since at that time there was no sphincterotomy or endoscopic therapy to actually relieve the ductal obstruction, he placed a pressure catheter into the pseudocyst and he kept filling it with saline. And every time he exceeded 25 millimeters of mercury of pressure, the patient reported pain. So that really built the premise for the ductal hypertension hypothesis.
One case.
Just one case, an N of 1 case. But interestingly, that was followed by many studies in Europe in the 1980s and early 1990s that showed when you actually had larger numbers of patients that the correlation between intraductal pressure and pain was largely sort of negated in subsequent studies.
Okay, but I think pressure measurement is difficult. So I think we were mainly going with the diameter, right?
They were going by diameter, and they were doing a lot of these studies in patients who were undergoing surgery, decompressive surgeries. So they would actually measure the pressure inside the duct at the time of actually undergoing a surgical drainage procedure.
And then assuming that if you have a bowel loop there, the pressure is gone.
Yeah, that's it's interesting because they didn't. They would try to take the pressure measurement prior to actually opening up the pancreas, and that was the simplest way they could do it at the time. But you're absolutely right. I mean, there's going to be some variation, and that was one of the big limitations of many of those studies. I think they were trying to puncture the pancreatic duct in a dilated segment just above the obstruction, upstream of the obstruction. And based on that measurement and what the patient's reported pain was before going into surgery, that's largely how they tried to.
But that's very vague, isn't it?
It is very vague.
I mean, is there really increased pressure, or is just it's dilated and no pressure like a sac?
It's actually very interesting because the pressure was actually broadly distributed. So you had patients who had as low as 10 millimeters of mercury, and you had others who had 50, 60, 70 millimeters of mercury pressure within the duct. And morphologically, they could appear exactly the same. So oddly enough, that I think that suggested that this is a much more dynamic and complex process than people have
exactly. I mean, even if you stay in the mechanistic thinking, there is the parenchyma around. So how thick it is, how firm it is, doesn't that play a huge role, or should it play a huge role?
Absolutely. And what we've realized over time is that more so than the pressure, the parenchyma is critical, because over there is where you largely have your pancreatic nerve distribution. And it's the inflammation of the nerves that ultimately leads in an increase in their density and volume. And we believe that is actually the pancreatic neuropathy that's taking place locally. And with time, we know that that actually is what eventually leads to sensitization, because you begin to have a barrage of nociceptive impulses from the pancreas traveling through the primary nociceptive afferents back to the dorsal root ganglion and then back up to the pain centers of the brain. And as long as there's nociceptive signaling that's occurring, or what we call a barrage effect, over time patients can develop both peripheral and central sensitization.
So that's a very different story, right? So we have to get away from the pressure hypothesis because the correlation is obviously weak.
That's absolutely correct.
It seemed to be logical, the only thing we could deal with by surgery, endoscopy. But what's the truth of pain?
Yes, is that it's probably a much more of a wiring problem than a plumbing problem. And the wiring really begins at the level of the pancreas and then makes its way back to the spinal cord and then into the centers of the brain, where we not only perceive pain, but are also highly responsible for our mood, our affect, our cognition, and so many other sort of psychological variables. And that's also why we think that patients who either have a predisposition to developing depression or anxiety are much more likely to amplify that pain response. And that's one big reason why no matter what intervention you pursue in a patient for pain, if you do not treat concurrent depression and or anxiety, they will generally not feel better.
So it's all about the mentality, the mood. Patients go into the race against the inflammatory pain. Is that what you think is the combination? Or?
I think it's the combination of both inflammation at the level of the gland, the way it interacts with the peripheral and central nervous system, and then the way it interacts with the pain centers, and the fact that those pain centers rely or are very close to the areas of the brain that are also mediating this affect and
But how
and
can
mood.
you possibly quantify or diagnose what's going on in the pancreas? Is morphology a good parameter?
Yeah,
There's all this US thing like strands and early chronic pancreatitis, which I was always very skeptical about. So how can we determine that, the degree of inflammation? Do you have to biopsy or?
Unfortunately, biopsy would probably be the most accurate. I think but you're absolutely right that the morphologic changes of the pancreas correlate poorly with pain. And we've now known that since 1980, and there have been some very large cohort studies that have been done that have shown that even if you take the most advanced morphologic features of chronic pancreatitis, they really don't correlate whatsoever with either pain pattern or pain severity. So, I think that's the other thing that has largely fed into the fact that even though we're, again, treating it as a plumbing problem, there's also, the other thing I think that's also important to remember is that about 10% of all chronic calcific pancreatitis patients have primary painless disease, and we have no idea why. So, I think all of these facts are underscoring the point that pain is complex, but probably not morphologic.
But how then to diagnose? I mean, you have something you call chronic pancreatitis, you have the pain. Is there any correlation, or does it make any sense would it make sense to systematically FNA those patients by US or maybe not?
I think at the present time, we're probably not quite there yet, only because of the risks posed by performing, invasive procedures and
But we think that you can't do much
Yeah.
damage to a chronically inflamed pancreas. So the pancreatitis rate after ERCP, if it's advanced, is probably lower.
That's true.
The same may apply to FNA, but would we get any meaningful information?
I think we have to stop thinking about trying to get tissue from the pancreas in order to either diagnose or phenotype pain. I think we have to think of pain as a separate entity, and we have to go after it with instruments and tools to try to attempt to determine, is this pain that's still largely in the organ or visceral in nature, or is it now central in nature and maybe more of a reflection of sensitization? Now, there are some tools that have been developed and that are in active use in research studies. And in fact, there was a couple of studies that are actually ongoing right now that are prospectively evaluating some of these tools to determine whether or not they can predict which patients are going to go on to have a positive outcome to even invasive treatments such as endoscopic decompression.
Which would be what, for example?
Some of the tools that are being used. So there was something called quantitative sensory testing. This was developed by a Swedish neurologist in the 1950s and been largely used in the neurologic and psychiatric disease space. But over years, there has been some adaptation of using these sensory testing instruments to phenotype pain in patients with chronic pancreatitis pain. A lot of that has been led by some of the efforts of my collaborators in Aalborg, Denmark, including Dr. Asbjørn Drews and Søren Olesen, who have done a really, really good work in attempting to come up with a simple battery of tests that can help us, at least in a very basic way, determine whether or not we believe pain is visceral or central in origin.
But they measure the perception?
Where it's a combination of tests that actually utilize tests such as a pinprick, pressure algometry, and a cold pressor test. Because what these do is they effectively are, when you induce experimental pain, then the patient, depending on their results from these testing algorithms, it gives us some sense of whether or not they may be sensitized. I think that's a simple way to describe it.
I mean, that might be a very crazy question when I hear that. Can you have chronic pancreatitis pain with a normal pancreas?
I think those patients probably don't have chronic pancreatitis, but we should always keep in mind that the most common cause of chronic abdominal pain in the world would be a disorder of the brain-gut axis. And I know there are a lot of people, of course, spending their time investigating that. But, if you go by prevalence studies across the population, 25 to 40% of individuals will at some point in their life experience symptoms that are very consistent with the disorder of the brain-gut axis.
But we're getting more and more away from pressure, from morphology, from histology, more into perception. So
correct.
And that's based on the fact that you see some morphologic changes in the pancreas and the patient has pain. But maybe there's no correlation at all.
Or it might be more correlated in the earliest stage of disease, and then as disease progresses, then the pain becomes more centralized. I think that's probably what happens, although it's very, very difficult to prove. I do think that tools and tests that get a better sense of how the brain functional connectivity works and what regions light up when a patient is in pain. So there have been such as functional MRI, or maybe using EEG, which is of course commonly used to diagnose patients with seizure disorder. There is some effort being put into sort of using this specifically for a variety of painful visceral disorders to see if it can better tell us which patients are really being driven by this perception or central phenomenon of pain. But
basically we're getting more and more away from the organ.
Absolutely.
Morphology and everything. So, if a patient comes to you, let's try to keep it simpler and with a diagnosis of chronic pancreatitis and pain. How much do you rely on which imaging, or is it a certain pattern of pain which you think it could be correlated? And how much do you trust morphology, and if so, which one?
I think I use morphology primarily to make a diagnosis, to make a diagnosis of the condition the patient has or does not have.
Which is an abnormal pancreas not being malignant.
Yeah, I generally have been, for diagnostic purposes, I've largely been relying on the definite Mannheim criteria. Which of course were first published in 2007 and have been around a long time, because I'm not really a believer in minimal change early. Yeah. To me, early chronic pancreatitis is recurrent acute pancreatitis. And we know that about 3/4 of individuals with chronic calcific pancreatitis at this moment in time are individuals who had a history of recurrent acute pancreatitis. So I think that's important. We can't separate out the history and the risk factors of these individuals. So I think it's very important to clinically contextualize your evaluations. But I think in those individuals who do have chronic pancreatitis, and the next question is, what are we going to offer them, from the standpoint of treatment? So if I'm convinced that somebody has chronic pancreatitis, then I generally try to, and they have pain, I try to generally differentiate them into small or large duct patients. I still think that it's reasonable, until we have a better way of figuring out which patients are going to most benefit from endoscopy, to probably clear the obstruction in those patients with pain. But my approach that I would say, of course, and as an endoscopist and a pancreatologist, I would say probably where my approach differs than many endoscopists is that after I clear the duct of the obstructing stones and correct strictures, if a patient still has pain, then I generally go towards neuromodulators. And the neuromodulator, which I think has the most evidence supporting its use at the present time, based on 3 randomized controlled trials, is actually pregabalin. And what's interesting is that pregabalin works well at treating the peripheral sensitization component of pain, really at the level of the spinal cord. And I have had wonderful success using this drug in terms of mitigating and reducing pain in patients. But every time I try to convince my endoscopy colleagues that, look, if your patient in whom you've done a great job clearing their ductal obstruction is still having pain, that you should consider using a gabapentinoid class medication, they're like, oh, gabapentinoid, I don't know if I want to do that. Everyone seems to be okay with giving patients fentanyl and opioids, especially in the United States, but for some reason they're very scared of or shy away from using these neuromodulatory type drugs.
I mean, what we sadly observe is the obsession with clearing the duct, and if it doesn't help, then the stent is too big, too small, too long, too short, and you try forever before you say, okay, it was try and error, it's probably the error.
Yeah, that's correct.
And let's go somewhere else, right? So that's
absolutely correct. And I think in this country, a lot of those patients who continue to have pain despite successful endoscopic therapy are potentially sent to surgery. So they're getting another invasive, life-altering procedure, or they're sent to chronic pain specialists who often just escalate opioids because they're generally not as comfortable treating visceral pain disorders as they are musculoskeletal pain disorders. So I think that there's a lot of harm that's unfortunately done to these patients. But I think as a gastroenterology community, and more specifically as an endoscopy community, I think we should take greater ownership of these patients. And even if we've corrected what we believe is an obstructive process, that we should be ready to and become comfortable with using some of these medicines. At the end of the day, we are internists. And I believe that we'll do a lot of our patients more good that way.
Okay, so stop the endoscopic circles at some stage and admit that obstruction was not causative.
Yeah.
What about celiac plexus neurolysis? This used to be fashionable. I think it's not used so often anymore, right?
Yeah, celiac plexus neurolysis, at least in the United States, was largely reserved for those patients with painful pancreatic adenocarcinoma.
But there were also studies in chronic pancreatitis.
There were some small studies where they looked at both celiac plexus blockade with bupivacaine and steroids, as well as the smaller numbers of patients using the neurolytic. What's interesting is that there was 5 years ago there was a randomized controlled trial from Japan that showed that celiac neurolysis, even the setting of pancreatic adenocarcinoma, there was no difference between the patients who were randomized to receive celiac neurolysis compared to just standard of care, which is largely opioids in the pancreatic cancer population. In chronic pancreatitis, I think the problem is, again, there has not really been a good trial. I would say some of the earlier studies may have even enrolled patients who didn't have chronic pancreatitis. And I think if we go back and we look at the systematic reviews that have been done of those patients, there was about a 50% response rate, but it would usually wane within a couple of weeks. But we've never had a good sham control trial. I know that some of our colleagues in Orlando, Florida, have started sort of a U.S. pancreatic study group, and they're conducting something called the EPOC trial. So they are going to conduct a sham control trial of EUS with celiac plexus blockade for patients with pain and chronic pancreatitis. I think the only thing that comes into question in my mind with that study is that the entry criteria is simply 5 or more EUS criteria for chronic pancreatitis, which we know can be problematic. In some ways, I think it would be better if they looked at patients who maybe had chronic pancreatitis by the definite Mannheim classification. But we can see what comes out of that. I suspect that if I had to give you a hypothesis, I suspect there's going to be no difference.
Okay, but conceptually, would it make sense? So, is it really the pathway to the brain? Is it via the celiac plexus, or is that a misconception as well?
It's actually a great question, and what's interesting also is that there's many pathways for pain to go from the pancreas back into the central nervous system, without making this very complicated. And as a result, I like to think of it as a highway with many exits. Right. So even if you shut one exit, pain will find a way to off-ramp off a different exit. So I think that's important. I think we can all relate to that.
That's a nice picture.
Yeah, I think that's a good way to think of it. And the other thing to keep in mind is whether you're using blockade or neurolysis, you don't really actually ablate these nerves, because nerves are very hard to get rid of. They really do an amazing job of regenerating. And I think that's another thing that at least our basic science colleagues have taught us over the years, is the fact that these nerves have tremendous capabilities of coming back together and rejoining and sort of partnering up with their ends and terminals.
In between there was the ganglia story, so you had to inject into the ganglia, but it didn't hold true either, right?
That's right. That's also not been subjected, to the best of my knowledge, to a randomized trial. I think they had initially shown that there would be an increased response, especially in the cancer population, to celiac ganglion neurolysis. But then I think Mike Levy and his colleagues at the Mayo Clinic showed that there, in fact, was a higher mortality in those patients who received a direct ganglion injection. And this was adjusting for all the other variables that certainly would be at play in those patients with at least pancreatic cancer pain. Yeah.
So we have some messages: don't stick to endoscopy. Try to influence the pain perception. What's in for the future?
Oh, this is a great question. There is a lot of research being done on looking at different neuromodulators to actually tackle the pain of not only chronic pancreatitis but other visceral disorders, both at the level of the gland or in the organ, as well as back into the nerves that synapse at the level of the spinal cord, and then up along into the central nervous system. There are a lot of targets. I think we've been somewhat, we've only really been focusing on the one that's readily available, and that's gabapentinoid and pregabalin class of medications. But I think in the future there's going to be a lot of opportunity to potentially target other neurotransmitters that are involved in the propagation of these painful nerve impulses. I think one target that just comes to mind right off the top of my head is CGRP. Anti-CGRP monoclonal antibodies have been developed to treat migraine headaches. And interestingly enough, CGRP might be quite operative in the pain pathophysiology of chronic pancreatitis. So that certainly represents one target that I think we might be able to take advantage of in the future.
So it's more for the pain people than for the decompression people at the end.
Absolutely. Well, but at the same time, I think I think GI doctors could potentially get more involved in pain phenotyping. I think that might that might add to our diagnostic armamentarium. I think the other thing that's also very exciting, and that a lot of endoscopy accessory and device manufacturers actually have divisions of, is neuromodulation. So neuromodulation doesn't simply have to be used to treat musculoskeletal disorders, and in fact, there's a lot of interest in using these neuromodulatory devices to potentially treat visceral pain disorders. There are some studies actively being pursued looking at transcutaneous electric nerve stimulation, or TENS units, to treat chronic pancreatitis pain. And there's even new generations of that same equipment that are now available that also potentially could be used that way. The most provocative thing I've seen recently, though, is a group that is trying to use transcranial direct current stimulation of regions of the brain that we believe are pivotal in the placebo and sham response. So that if you can activate those regions, you might actually get the release of endorphins.
Activate placebo regions of the brain.
You're basically activating the placebo response.
That's fascinating.
Yes.
So that goes far beyond endoscopy.
Yes.
Vikesh, I thank you very much. I think it was really very interesting to see how complex that is. And the message for us is, don't be too mechanistic, at least not long term.
That's absolutely right.
Yeah. Thanks very much.
Thank you, Thomas.
Thank you for watching, and we'll be back next week.